discussion today is normal labor. What is labor? It is the series of events that take place in the genital organs in an effort to expel the viable products of conception out of the womb through the vagina into the outer world. If it occurs prior to 37 completed weeks of pregnancy, we call it preterm labor. Now, labor is characterized by the presence of regular uterine contractions along with effacement and dilatation of the cervix and descent of the fetal head. A parturian is a patient in labor, and parturition is the process of giving birth. Delivery is the expulsion or extraction of a viable fetus out of the womb. It is not synonymous with labor. Delivery may take place without labor, as in elective cesarean section. It may be vaginal, either spontaneous or aided, or it may be abdominal. What is normal labor? Labor is said to be normal if it fulfills the following criteria. It should be spontaneous in onset and should occur at term pregnancy, with vertex presentation without undue prolongation, natural termination with minimal aids, without causing any complications to the mother or the baby. Coming to the causes of onset of labor. Uterine distension. Stretching effect on the myometrium by the growing fetus and liquor amni increases the gap junction proteins in the receptors for oxytocin and specific contraction associated proteins. Next is the fetoplacental contribution. A cascade of events take place that activates the fetal hypothalamic pituitary adrenal axis just prior to the onset of labor. This results in increased level of corticotropic releasing hormone, which leads to increased release of ACTH, which activates the fetal adrenals, leading to secretion of cortisol, which in turn causes accelerated production of estrogen and prostaglandins from the placenta. Role of estrogen. Now, it has got several mechanisms of action, such as it increases the release of oxytocin from the maternal pituitary. It promotes the synthesis of myometrial receptors for oxytocin, that is by 100 to 200 folds. Also, there is increase in prostaglandin synthesis and increase in gap junction in the myometrial cells. It also accelerates lysosomal disintegration in the decidual and amnion cells, which leads to increased prostaglandin synthesis, prostaglandin F2 alpha. It stimulates the synthesis of myometrial contractile protein, that is ectomyosin, through cyclic AMP. Plus, it increases the excitability of the myometrial cell membranes. Role of progesterone. Increased fetal production of DHEAS, that is dihydroepiandrosterone sulfate, and cortisol inhibits the conversion of fetal pregnenolone to progesterone. Therefore, the progesterone level falls just before labor. Prostaglandins. Prostaglandins are important factors. They help to both initiate and maintain labor. Sites of synthesis are the amnion, chorion, decidual cells, and myometrium. Synthesis is triggered by various factors such as rise in estrogen level, glucocorticoids, then mechanical stretching in late pregnancy, increase in cytokines interleukin 1, interleukin 6, and tumor necrosis factor, any kind of infections, vaginal examination, separation or rupture of the membrane. The prostaglandins help to enhance the gap junction, that is the intermembranous gap between two cells through which the stimulus flows. So this is the parturition cascade, where we can see involvement of fetal factors, placental factors, as well as maternal factors in the onset of labor. Now, let us briefly discuss the contractile system of the myometrium. The basic elements involved in the uterine contractile systems are actin, myosin, adenosine triphosphate, the enzyme myosin light chain kinase, and calcium molecules. The structural unit of a myometrial cell is the myofibril, and it contains the proteins actin and myosin. The interaction of these two proteins is required for muscle contraction. The key process in this interaction is the myosin light chain phosphorylation, which is controlled by myosin light chain kinase. The enzyme oxytocin acts on myometrial receptors and activates phospholipase C, which leads to increase in intracellular calcium level. Calcium is essential for activation of myosin light chain kinase, and it binds to the kinase as calmodulin calcium complex. Intracellular calcium levels are regulated by two mechanisms. One is influx across the cell membrane and release from intracellular storage sites. Calcium is stored within the cells in the sarcoplasmic reticulum as well as in the mitochondria. Progesterone and cyclic AMP promote calcium storage at these sites, whereas prostaglandin F2 alpha, E2 and oxytocin helps to stimulate its release and therefore helps in bringing about muscle contractions. So what happens whenever there is increase in intracellular calcium, there will be increase in calmodulin calcium complex formation, which will activate the myosin light chain kinase. So there is phosphorylation of the myosin, which binds to actin and leads to myometrial contraction. And the opposite happens when there is decrease in intracellular calcium level, and that will lead to myometrial relaxation. Now let us discuss the stages of labor. The first stage, it starts with the onset of true labor pain and ends with the full dilatation of the cervix. The average duration is 12 hours in primi gravide and 6 hours in multipare. Second stage, it starts from the full dilatation of the cervix and ends with the expulsion of the fetus from the birth canal. There are two phases in the second stage. One is the propulsive phase, that is full dilatation of the cervix up to the descent of the presenting part to the pelvic floor. Next is the expulsive phase, which is distinguished by maternal bearing down efforts and ends with the delivery of the baby. Duration being 22 hours in primi gravide and 30 minutes in multipare. Third stage. It begins after the expulsion of the fetus and ends with expulsion of the placenta and the membranes, that is the afterbirths. Average duration is 15 minutes in both primi gravide and multipare. However, in active management of labor, the duration is usually reduced to 5 minutes. Then there is also the fourth stage, which is the stage of observation, which is for at least 1 hour after expulsion of the afterbirths. In this phase, we generally monitor the mother for her vitals, which includes her temperature, pulse, her blood pressure, then uterine, whether uterus is contracted or not, and whether there is any vaginal bleeding. The baby is also examined. Events in the first stage of labor. The first stage is chiefly concerned with the preparation of the birth canal so as to facilitate the expulsion of the fetus in the second stage. So the main events that occur in the first stage are dilatation and effacement of the cervix and full formation of the lower uterine segment. Now what is lower uterine segment? It is limited superiorly by the physiological retraction ring and inferiorly by the fibromuscular junction of the cervix and the uterus. Now dilatation of the cervix. Now prior to the onset of labor, in the pre-labor phase, there may be certain amount of dilatation of the cervix, which is specially noticed in multipara and some primi gravida. Now what are the factors which are responsible for cervical dilatation? One is uterine contraction and retraction. Now, what happens? The longitudinal muscle fibers of the upper segment of the uterus are attached with the circular muscle fibers of the lower segment and the upper part of the cervix in a bucket holding manner. So, whenever there is uterine contraction, the cervical canal is opened up from above downwards, and at the same time it becomes shortened. There is coordination between fundal contraction and cervical dilatation, and this is referred to as polarity of the uterus. The upper segment contracts, retracts and pushes the fetus, whereas the lower segment and the cervix dilates in response to the forces of contraction of the upper segment. Next we come to fetal excess pressure. In labor with longitudinal lie, there is a tendency of straightening out of the fetal vertebral column, as because there is contraction of the circular muscles of the body of the uterus, and this leads to transmission of the fundal contraction through the podalic pole into the fetal axis, which helps in mechanical stretching of the lower segment and opening up of the cervical canal. The third factor is formation of bag of membranes. Now the membranes are usually loosely attached to the decidua which lines the uterine cavity except over the internal os. So in vertex presentation, the girdle of contact of the head, being spherical, fits well with the wall of the lower uterine segment. This divides the amniotic cavity into two components. The part which lies above the girdle of contact is the hindwaters, and the part below it is the forewaters. So, with the onset of labor, the membranes which are attached to the lower uterine segment get detached, and whenever there is rise in uterine pressure during contraction, there is herniation of the membranes to the cervical canal. There is ball valve action by the well-flexed head. The uterine contractions generate hydrostatic pressure in the forewaters, and this helps to dilate the cervical canal like a wedge. The last factor is visa turgo. This is the final phase of dilatation and retraction of the cervix, and it is achieved by downward thrust of the presenting part of the fetus along with upward pull of the cervix over the lower segment. Next, to effacement of the cervix, also known as taking up of the cervix. It is a process by which the muscle fibers of the cervix are pulled upwards and merges with the fibers of the lower uterine segment. The cervix becomes thin during the first stage of labor or even before that in primary gravity. In primary gravity, effacement precedes dilatation of the cervix, whereas in multipara, both the processes occur simultaneously. So this is a diagrammatic representation of dilatation and taking out of the cervix in primary gravity and in multipara. Now let us discuss the events which take place in the second stage of labor. So one is the propulsive phase, which is the phase from full dilatation of the cervix to the stage when the head touches the pelvic floor. And next is the expulsive phase, where the mother has got the desire to bear down and push until the baby is delivered. Now with the full dilatation of the cervix, the membranes usually rupture and there is escape of good amount of liquor amniote. So this leads to reduction in the volume of the uterine cavity. Simultaneously, uterine contractions and retractions become stronger. The uterus becomes elongated during contraction, while the antero-posterior and transverse diameters are reduced. This elongation is partly due to contractions of the circular fibers of the uterus so as to keep the fetal axis straight. Delivery of the fetus is accomplished by downward thrust that is offered by uterine contractions supplemented by voluntary contraction of the abdominal muscles, also known as the bearing down efforts, against the resistance that is offered by the bony and soft tissues of the birth canal. This diagram shows the expulsive forces in the second stage. So we can say that the increased intra-abdominal pressure augments the downward expulsive force of uterine contraction. Now we come to the events that take place in the third stage of labor. The third stage of labor comprises the phase of placental separation, its descent to the lower segment, and finally its expulsion with the membranes. Now, how does placental separation occurs? At the beginning of labor, the placental attachment roughly corresponds to an area of about 20 cm in diameter. But once the baby is born, the uterus measures about 20 cm vertically and 10 cm anteroposteriorly, and its shape becomes discoid. The wall of the upper segment is much thickened, while the lower segment becomes thin and flabby and is thrown into folds. The cavity is much reduced to accommodate only the afterbirths. Marked retraction reduces effectively the surface area at the placental site to about its half. But the placenta being inelastic, it cannot keep pace with such an extent of diminution, which results in its buckling. A shearing force is instituted between the placenta and the placental site, and this brings about its ultimate separation. The plane of separation is through the deep spongy layer of the decidua basilis. Separation mostly starts at the margins. This is known as the Matthews-Duncan separation, but it may also start at the center of the placenta, which is referred to as sculls. Now, separation of the membranes. The membranes, which are loosely attached in the active part, are thrown into multiple folds, and those attached to the lower segment are already separated during its stretching. Separation of the membrane is facilitated partly by uterine contraction, but mostly by the weight of the placenta as it descends down the active part. After complete separation of the placenta, it is forced down into the flabby lower uterine segment or upper part of the vagina by effective contraction and retraction of the uterus. Thereafter, it is expelled out either by voluntary contraction of the abdominal muscles or by manual procedure. Bleeding from the torn sinuses following placental expulsion is effected by complete retraction, thrombosis, and apposition of the uterine walls. Thank you. Continue with my discussion of normal labor. So let us begin with mechanism of normal labor. What is mechanism of labor? It is the series of movements that occur on the head in the process of adaptation during its journey through the pelvis. While the principal movements are taking place in the head, the rest of the fetal trunk is also involved in it, either participating in or initiating the movement. In normal labor, the head enters the brim more commonly through the available transverse diameter, that is in around 70%, and to a lesser extent through one of the oblique diameters. Accordingly, the position is either occipitolateral or oblique occipito-anterior. The left occipito-anterior position is a little more common than the right occipito-anterior, as the left oblique diameter is encroached upon by the rectum. The engaging anteroposterior diameter of the fetal head is either suboccipito-brachmatic, which is 9.5 cm, or it is suboccipito-frontal, that is 10 cm, which is in slight deflexed head. The engaging transverse diameter is the biparietal diameter, which is 9.5 cm. Now, what are the principal movements involved in the mechanism of normal labor. These are engagement, descent, flexion, internal rotation, crowning, extension, restitution, external rotation, and expulsion of the trunk. Let us discuss each of them separately, one by one. Engagement. This occurs when the largest diameter of the fetal head descends into the maternal pelvis. The term engagement means when the widest part of the fetal head successfully negotiates its way down into the maternal pelvis. It is identified by abdominal palpation where the fetal head is 3/5 palpable or less. The sagittal suture is frequently deflected either posteriorly to the promontory or anteriorly to the symphysis pubis. Such lateral deflection of the fetal head is known as anterior asyncretism, also known as Nagel's obliquity, and posterior asyncretism, that is Litzmann's obliquity respectively. In primigravida, it mostly occurs before the onset of labor, while in multipara it may occur in late first stage of labor, sometimes even after rupture of membranes. So here you can see that the head is getting engaged. Descent. The fetus descends into the pelvis. It is a continuous process which is more pronounced in the second stage. In primigravida, it is more likely to occur from 38 weeks gestation onwards, whereas in multigravida, it may not occur until labor is well established. Descent is encouraged by increased frequency and strength of uterine contractions during labor with fundal dominance along with retraction. Also, it is encouraged by bearing down efforts of the mother and straightening of the fetal ovoid. As the head descends, it moves towards the pelvic brim in either the left or right occipito-transverse position. Flexion. As the fetus descends through the pelvis, fundal dominance of uterine contraction exerts pressure down the fetal spine towards the occiput. At the same time, resistance is being offered by the pelvic floor, the unfolding cervix, and the walls of the pelvis. When this occurs, the fetal neck flexes, which allows the circumference of the fetal head to reduce to suboccipito-pragmatic. This is explained by the two-arm lever theory. In this position, the fetal skull has a smaller diameter which assists its passage through the pelvis. So here we can see flexion of the fetal head that has started to occur. Now, internal rotation. There are several theories which explains internal rotation of the fetal head. One is rotation by law of pelvic floor or Hart's rule. The pelvic floor has a gutter shape with a forward and downward slope. With each contraction, the fetal head stretches the levator ani, particularly that half which is in relation of the fetal occiput. Following the contraction, there is elastic recoil of the levator ani, which supports a small degree of rotation. Regular contractions eventually lead to the fetal head to rotate from the left or right occipito-transverse position a total of 90 degrees to an occipito-anterior position so that it lies under the subpubic arc. The second theory is the pelvic shape. Forward inclination of the pelvic side walls, narrow bispinous diameter, long anteroposterior diameter of the outlet results in accommodation of the long axis of the head in the long anteroposterior diameter of the outlet. Next is the law of unequal flexibility. That is, inequalities in the flexibilities of the component parts of the fetus also explains the internal rotation that takes place. The factors which favor anterior internal rotation of the head are a well-flexed fetal head, efficient uterine contraction, favorable shape of the mid-pelvic plane, tone of levator ani. Internal rotation may occur at various levels, but most commonly it occurs at the level of the pelvic floor. It results in torsion of the fetal neck. The shoulders move to occupy the oblique diameter if its original position was occipitolateral, so that the torsion that is sustained is not more than 1/8 of a circle. So here we can see internal rotation is occurring. Now what is crowning? When the widest diameter of the fetal head stretches the pelvic outlet, the fetal head is considered to be crowning. This is clinically evident when the head, which is visible at the vulva, no longer retreats between contractions. Complete delivery of the head is now imminent. Extension of the presenting part. The occiput slips beneath the subpubic arc, allowing the head to extend through couple of force theory. That is, the driving force pushes the head downwards, whereas pelvic resistance is exerted in two directions, that is upwards as well as forwards. The fetal head is now born. So successive parts to be born are the vertex, the brow, followed by the face, so that the fetus will now be facing the maternal back with its occiput anterior. Restitution. It is the visible passive movement of the head due to untwisting of the neck that is sustained during internal rotation. It occurs through 1/8 of a circle in the direction opposite to that of internal rotation. The occiput now points to the side to which it originally lay. External rotation. During the next contraction, the shoulders, having reached the pelvic floor, will complete their rotation from a transverse position to an anterior posterior position. Evidence of this maneuver happening inside can be visualized by seeing the head rotating externally as the fetus keeps its spine aligned. Finally, we come to delivery of the shoulders and the body. After the shoulders are positioned in the antero-posterior diameter of the outlet, further descent occurs till the anterior shoulder escapes below the symphysis pubis. By lateral flexion of the spine, the posterior shoulder sweeps over the perineum. The rest of the trunk is expelled by lateral flexion. So here we can see delivery of the shoulder and then the trunk. To summarize the mechanism of labor, it begins with engagement. The diameter of engagement is the available transverse diameter of the inlet in 70% of cases, and in mostly the rest of the cases it is one of the oblique diameters of the pelvic inlet. The engaging diameter of the fetal head may be the suboccipitobregmatic, that is 9.5 cm, or suboccipitofrontal, that is 10 cm. Engagement followed by increasing flexion, then internal rotation of the occiput anteriorly to 2/8 of a circle, and simultaneous rotation of the shoulders to 1/8 of a circle, so that the degree of torsion of the neck is 1/8 of a circle. Then crowning, delivery of the head by extension, restitution, external rotation of the head, and delivery of the shoulders and trunk by lateral flexion. And descent is a continuous process that occurs all throughout. Now let us discuss the management of each stage. First stage. The principles are non-interference with watchful expectancy so as to prepare the patient for natural birth. Here we need to monitor carefully the progress of labor, the maternal condition and the fetal behavior, so that we can detect any intrapartum complications early. Actual management. So general management includes antiseptic dressing, encouragement, emotional support and assurance to the mother, and constant supervision. An enema with soap water or glycerin suppository may be given. Then in the early stage, patient may be allowed to walk about till the membranes are intact. This helps to prevent venocaval compression and also descent of the head. Food is withheld during the active labor. Fluids in the form of plain water or fruit juice may be given. An IV fluid with Ringerl lactate solution is usually started whenever we anticipate any intervention. Bladder gate is to be taken and pain relief may be done with common analgesics. Partograph. What is partograph? It is a composite graphical record of key data, both of the mother and the fetus during labor, entered against time on a single sheet of paper. In cervicograph, the alert line starts at 4 cm as per WHO. 4 cm of cervical dilatation and ends at 10 cm dilatation. And the action line is drawn 4 hours to its right and it is parallel to the alert line. In a normal labor, the cervicograph should be either on the alert line or to its left. If it falls on the zone 2, it is abnormal and needs to be reassessed. And if it falls on zone 3, assessment should be done by a senior person and early decision is to be made regarding for termination of labor or for augmentation of labor. So here we can see a partograph. The top you can see plotting of the fetal heart rate, then amniotic fluid. It is C if the liquor is clear, then M if it is meconium stain, and in case of intact membrane we write I. Then presence of molding. Then here we plot the dilatation of cervix, which is plotted with the symbol X, and descent of the head is plotted with the symbol dot. It is plotted against the duration. Here we can see plotting of uterine contractions. So we count the number of contractions in 10 minutes. So accordingly the number of squares we shade it, and depending on the intensity of contraction, if it is a weak contraction that it lasts less than 20 seconds, so it is the shading is dotted. If the contractions last 20 to 40 seconds, we call it moderate contraction. So shading is in the form of oblique lines, slanting lines. And in case of strong contractions lasting more than 40 seconds, we color the whole box. It is whole box is shaded completely. Next is, if we are using oxytocin, we need to mention the units per liter of oxytocin use and drops per minute. Any other drugs and IV fluids that is used need to be written here. The pulse and blood pressure is recorded here. Pulse is by dotted lines which are joined, and blood pressure, systolic and diastolic blood pressure is recorded by two-headed arrows. The temperature record is also maintained, and urine for protein, acetone, glucose and volume is plotted in the lower part. Now what are the components of a partograph? It begins with the patient details, the identification points of the patient. The time is, it begins it is recorded at early interval. 0 time for spontaneous labor is the time of admission in the labor ward, and for induced labor it is the time when we start induction. Fetal heart is to be plotted at intervals of every 30 minutes. Then state of membrane and color of liquor, already I have mentioned. I for intact membrane, C for clear liquor and M for meconium stain lacquer. Cervical dilatation and descent of the head I have shown you. Then uterine contractions I have shown you. Drugs and fluids, blood pressure every 2 hourly, pulse at intervals of every 30 minutes. And oxytocin, urine analysis and temperature record. What are the advantages of a partograph? A single sheet of paper can provide details of all necessary information at a glance. No need to record the labor events separately. It can predict deviation from normal progress of labor early so that we can take appropriate steps. It facilitates handover procedure. Introduction of partograph in the management of labor has helped to reduce the incidence of prolonged labor as well as the cesarean section rate, leading to improvement in maternal morbidity as well as perinatal morbidity and mortality. Management of the second stage. Principles are to assist in the natural expulsion of the fetus slowly and steadily and to prevent perineal injuries. How do we conduct the delivery process? For delivery of the head, the principle that is mainly followed is to maintain flexion of the head to prevent its early extension and regulate its slow escape out of the vulval outlet. During delivery of the shoulders, we should not act hastily. We should wait for the uterine contractions to come and for the movements of restitution and external rotation of the head to occur naturally. For delivery of the trunk, after delivery of the shoulders, the forefinger of each hand are inserted under the axillae and the trunk is delivered by lateral flexion gently. For managing the third stage, there are two methods. One is the expectant management and next is the active management, which is the preferred method. The underlying principle in active management of third stage of labor is to excite powerful uterine contractions within 1 minute of delivery of the baby by giving parenteral oxytocin. This facilitates early separation of the placenta and also produces effective uterine contractions following separation of the placenta. Advantages of active management are: it helps to minimize blood loss approximately to 1/5 and to shorten the duration of the third stage to half. The only disadvantage is there is slight increased incidence of retained placenta, that is 1 to 2%, and consequent increased incidence of its manual removal. Of course, accidental administration during delivery of the first baby in case of undiagnosed twins may produce grave danger to the unborn second baby caused by asphyxia due to tetanic contraction of the uterus. So, we should limit its use in twins. It should be administered, the oxytocin drug should be administered only following delivery of the second baby in case of twin deliveries. To be effective, it should be administered in proper time followed by rapid delivery of the placenta. It is an ideal procedure for cases which are likely to develop postpartum hemorrhage, such as cases delivered vaginally under anesthesia, then anemia cases, hydramnios, multiple pregnancy, brain multipare, and those with previous history of postpartum hemorrhage. But ideally, active management of third stage of labor should be done in all cases. Procedure is to inject oxytocin 10 units intramuscularly or methyl argometrin 0.2 mg intramuscularly within 1 minute of delivery of the baby. The placenta is expected to be delivered soon after delivery of the baby, and if it is not delivered, it should be delivered forthwith by controlled cord traction, that is modified Brand-Andrews technique, after cord clamping while the uterus remains contracted. Management and other is the active management. Now, in assisted expulsion of the placenta, there are two methods. First is the controlled contraction or modified Brand-Andrews method, which is the most commonly followed procedure. The palmar surface of the fingers of the left hand is placed above the symphysis pubis, approximately at the junction of the upper and lower uterine segment. The body of the uterus is pushed upwards and backwards towards the umbilicus, while by the other hand, steady tension is given in downward and backward direction, holding the clamp until the placenta comes out of the introitus. It is more an uterine elevation which facilitates expulsion of the placenta. This procedure is to be adopted only when the uterus is hard and well contracted. And the next is the fundal pressure method. Here the fundus is pushed downwards and backwards after placing 4 fingers behind the fundus and the thumb in front of the uterus, using the uterus as a sort of piston. Pressure is to be given only when the uterus becomes hard. The pressure is to be withdrawn as soon as the placenta passes through the introitus. This method is preferable to cord traction when the baby is macerated or premature, because in such cases the tensile strength of the cord is much reduced and it may be accidentally torn, which is not likely to cause any problem.